Hello, and welcome to another video. Today we'll be discussing orbital cellulitis, quite a common condition that we often see in the pediatric population. So let's take the scenario. A child comes into hospital with a unilateral swollen eye. The question that should immediately come to mind is, does this child have orbital cellulitis? Why? Well, because it is a sight-threatening emergency, as complications can lead to optic atrophy, retinal vein occlusion, meningitis, or even the potential for death, although this is rare. It's important to distinguish between the two causes of a swollen eyelid, and both need to be on your differential: orbital cellulitis and preseptal cellulitis. There are a few signs that help you allow you to differentiate between the two common causes of a swollen unilateral eyelid in a child. In the case of preseptal cellulitis, normally the eyeball is not proptosed, and there is a normal assessment of the ocular motility, visual acuity and colour vision. Equally, there's no relevant afferent pupillary defect in preseptal cellulitis. In comparison to orbital, or also known as postseptal cellulitis, proptosis is usually present, and often there is huge abnormality on the ophthalmology exam, where the ocular motion or motility is completely restricted, or there is ophthalmoplegia. There's equally reduced visual acuity, reduced colour vision, and often there can be a present relevant afferent pupillary defect. So let's talk about the management of both conditions. So if you think your patient most likely has preseptal cellulitis, then be rest assured that your patient will probably only require some oral antibiotics and an outpatient department review. However, orbital cellulitis, if it's your top differential, needs to be treated empirically. All patients with a diagnosis of orbital cellulitis, or in cases where it cannot be excluded, have to be admitted to hospital. Children admitted under the joint care of the Pediatric ENT and Ophthalmology Unit, and the majority of patients under the age of 9 develop it secondary to ethmoidal sinusitis or an abscess following an upper respiratory tract infection. Further imaging such as MRI or CT scanning need to be considered and indicated in cases of orbital cellulitis, as they often might show fat stranding or inflammation of the extraocular muscles, as well as anterior displacement of the globe, which we call proptosis. A CT is always indicated, especially if there's optic neuropathy. The culprit organisms that tend to be associated with orbital cellulitis are aerobic organisms such as Streptococcus pneumoniae, Moraxella catarrhalis, and Haemophilus influenza, and they are very much responsive to IV antibiotics. So in such scenarios that orbital cellulitis is suspected, patients need to be started on IV antibiotics as soon as possible. Often, depending on the local hospital policy, IV ceftriaxone and metronidazole should be considered. If there is evidence of the patient improving or being clinically stable for the last 24 hours, including observations that tend to be naught or afebrile, then there's a switch from the IV antibiotics to oral antibiotics. Swapping, for example, to coamoxiclav oral for a 5 to 7 day course. If there is no clinical improvement despite IV antibiotics or oral antibiotics, then repeat imaging such as a CT, discussion with microbiologists in terms of the antibiotics, need to be considered. So to summarize, patients presenting with unilateral swelling, painful movements of the eyes, as well as an eye that's protruding forward, you need to consider the diagnosis of orbital cellulitis. You immediately admit them and have a multidisciplinary approach involving pediatricians, ear, nose, throat specialists and ophthalmologists to review the patient. Imaging is always indicated, including a CT scan, to ensure that no tracking of infection has occurred into the CNS, and IV antibiotics need to be started immediately and empirically once a diagnosis of orbital cellulitis is suspected. If they've been afebrile for the last 24 hours or clinically stable, one can consider an oral switch. Thank you for listening to this educational video about orbital cellulitis. We hope you've learnt something.